Today we are going to talk about thyroid swelling, goiter, as well as nodule. And these are important manifestations that we need to worry about. And the concerns of that are very, very relevant because we are worried not only about thyroid functions, but also about the aspects of whether there's a chance of malignancy or not. So we'll start off with this case, 16-year-old boy, follow-up case of Hodgkin's disease. And in this scenario, what was happening was that this child had received cervical radiation earlier. And on reporting, what was found was that his FT4 was normal and TSH was slightly elevated. TPO was negative. There was a small nodule which was present in that perspective, and there was no treatment which was given in that regards. Now, we need to understand that when we are looking at thyroid functions and a thyroid swelling, we also need to look at the background of the particular individual. And if there is a history of radiation, there is a very strong risk of having malignancy, which we need to be bothered about and concerned about in that perspective. So clearly in this case, on follow-up, this nodule progressed and there was a papillary carcinoma which developed. So we need to understand that when we have a thyroid nodule, there is a high chance of malignancy to begin with. The chances become more particularly if there are some underlying disorders, especially in the setting of radiation, which becomes relevant. All of you can go and have a look at our website, learning.growsociety.in, where there are a lot of courses available regarding pediatric endocrinology. We run a number of programs in terms of lecture series, in terms of grand rounds. Our books are there for publication, and also we have got the application which we can use. So today we're going to talk about thyroid swelling, which is quite important from both pediatric as well as pediatric endocrine perspective. So when we look at the thyroid gland, we all know that the pituitary controls the thyroid using the TSH, which is acting on the TSH receptor, which causes the thyroid growth. Now, TSH is the potent thyroid stimulating hormone. So if somebody has got a high TSH, that will stimulate the growth of thyroid, and that can ultimately lead to development of nodules and malignancies in these scenarios. So when we are treating somebody with a thyroid swelling, we don't want the TSH levels to be very high. As we discussed in the previous case, wherein we found that this child actually had a history of radiation, and that is something which caused all those problems in that perspective. Now, similarly, if there is a TSH receptor antibody, it is also going to work on the thyroid to increase the size of the thyroid gland. Now, function could be both hypothyroidism. If you have a blocking antibody or destruction of thyroid, you will have hypothyroidism. Or if it's a stimulatory antibody, you will have thyrotoxicosis. The other problem with the thyroid swelling can happen is the compression. So there could be a compression of the respiratory tract and dysphagia which may happen. Now, these are uncommon in most pediatric settings. The more common settings would be that swelling is there, but you don't have any compression because it tends to be softer in nature, and retrosternal extension is less common in pediatric age group, and these are pretty relevant from that perspective. Now, sometimes if the mediastinal part goes in, there could be an issue. Now, when we talk about goiter, it can largely be congenital or acquired. Congenital goiter could be because of a problem in thyroid hormone synthesis, in which the TSH will go up to compensate that. There could also be a problem of maternal antithyroid drugs, which can cross the placenta and they can cause large thyroid goiters, which can be present in that perspective, and also the TSH receptor antibody, which can be there. Rare causes include McCune-Albright syndrome, wherein you have got the increased action of the TSH receptor, or the GNAS defect, which is there, which causes increased thyroid. One of the major causes of a large goiter in a newborn would be the use of antithyroid drug like methimazole, which can cross the placenta, causing the thyromegaly by blocking. TSH receptor antibody can also cause neonatal graves. Very importantly, iodine exposure in the mother is something which is also known to have an impact in terms of the overall process. Older age group, again, TSH is a major factor as far as goiter development. So we have got the TSH, which is acting via the TSH receptor, in which you can have hypothyroidism like dysharmonogenesis, iodine deficiency, or the use of antithyroid drugs. These goiters are typically soft in nature. While if you have a TSH receptor stimulating antibody like causing Graves' disease or thyrotoxicosis, Here you will find a lesion which is more firmish in nature. So the nature of thyroid swelling will tell you the picture. If it's soft, it's most likely a dyshomogenesis or a quote unquote colloid goiter. While if you have a Graves disease, you will have a soft to firm goiter with increased vascularity resulting in bruit, which is there. There could also be infiltrative disorders like thyroiditis, infections in which you will have more firm and bossulated swelling. So the type of thyroid swelling will determine the type of clinical field will tell you which is the more likely diagnosis in that regards. Now, when you talk about thyroid nodule, that can be part of multiple scenarios. You can have somatic mutations in particular genes of thyroid growth, like TSH receptor mutation, and this thyroid swelling can typically happen in the form of adenoma. But there are other non-thyroidal cysts which can also be there. We can have lesions like a thyroglossal cyst. In the path of thyroid descent, you can have trapment which can happen. There could be a ectopic thyroid, and also there could be a malignancy which has got genetic, obviously, in that regards. Other swellings can also cause thyroid enlargements like teratoma, lymphoma, and I have even seen tuberculosis presenting just like a central neck swelling, which was found to have tuberculomas in that perspective. Now, thyroid nodules in children are common. 2% cases will have that, but if you follow them up over time, 75% of them are known to resolve over time. Malignancy risk is around 7 to 14%. So compared to adults, earlier we used to think it's much higher, but now it's pretty similar to the adult range of around 10% in that perspective. And very importantly, if you find an incidental thyroid nodule versus a nodule which is detected by a clinical examination, there's no difference in terms of malignancy outcome. So now I'll invite Dr. Nimesha to cover about the etiology of various types of thyroid swelling.
Could be TSH dependent, which includes dysharmonogenesis, iodine deficiency, Pendred syndrome, PPO, thyroglobulin defect, due to X2 defect, or due to maternal transfer of antithyroid drugs, iodine or amiodarone. It could be TSH independent, which can be present as thyrotoxicosis, like in Graves, TSH receptor mutation, or McCune outright, or like hypothyroidism in PR beta defect. It could present as a thyroid mass, which can be a DD of goiter, like hemiagenesis, thyroglossal cyst, neoplasm, can act like a differential diagnosis of goiters. Therefore, the disorders which included in the dysharmonogenesis are Pendred syndrome. The gene involved is SLC26A4, which results in deafness, renal tubular defects, and is a mild disease. TPO defect is severe with increased thyroglobulin and perchlorate discharge. UOX2 is due to defect in gene UOX2, which is transient, and thyroglobulin defect resulting in low thyroglobulin levels, and dehalogenase defect, which has variable onset. The neonatal Graves disease occurs due to maternal transfer of antibodies, TRAB antibodies, which can result in fetal tachycardia or hydrops, but it will self-reduce by 3 to 12 weeks. Ectopic thyroid occurs when there is a descent of thyroid gland from the foramen of cecum. That descent is arrested at some place. There is occurrence of ectopic thyroid, which has only follicular, there's no parafollicular part, only gland is present. And it presents like a goiter. On nuclear scan, it can be detected, can present like hypothyroidism. It moves with deglutition. Thyroglossal cyst, during descent of thyroid gland from foramen cecum to its usual place, the gland can persist in there. It moves with the tongue protrusion. It is usually euthyroid, and surgery is needed as it is a recurrent cause of infection and can develop into malignancy. Acquired goiter can occur due to infiltration, which include causes like thyroiditis, tuberculosis, histiocytosis, and colloid goiter. TSH-dependent causes, which resulting in hypothyroidism, include iodine deficiency, dysharmonogenesis, goitrogens, and due to drugs like anti-cancer drug or tyrosine kinase inhibitor drugs.
and thyrotoxicosis due to TSH-OMA and TR beta defect. TSH-independent defects include Graves' disease, McCune-Albright, and TSH receptor mutation. Autoimmune thyroiditis, most children who are predisposed to autoimmune thyroiditis are one with APS, type 1 diabetes, or celiac. They have family history of similar illness. Family history of autoimmune thyroiditis in sibling can be present. The presentation is goiter, which is usually firm and bosselated. Diagnosis is made using TPO antibody. There is 10% risk of them developing into hypothyroidism, and treatment should be started only if TSH is more than 10, and with TSH levels between 6 to 10 if TPO is positive. Iodine deficiency, areas with deficiency of iodine present or low supplementation of iodine can result in goiter. It has usually a mild hypothyroidism course, and diagnosis at community level can be done using urine iodine level, which is less than 50 microgram per liter. Goitrogens, common goitrogens is like amiodarone, which due to increase in iodine level affects TSH action. Thionamide, which using lithium can result in goiter. And goitrins and thiocyanate, which affects MDI1, can resulting in goiter development. Uh, Thiocyanate is present in maize and cassava, and cauliflower and turnip consist of goitrins. Drugs like phenytoin, phenobarbital, tyrosine kinase inhibitors, checkpoint inhibitors acts like goitrogens. This course is self-limiting, can result in mild hypothyroidism, and treatment is to stop the causative agent. Colloid goiter occur in a setting of puberty due to increased demand, commonly seen in girls, manifests like euthyroid, and on FNAC a colloid nodule, and on ultrasound a isoechoic nodule can be seen. It is a self-limiting condition and there is no requirement of treatment. Great. So due to increase demand during puberty.
So what all other glands which increase during puberty because of increased demand?
Pituitary.
So pituitary enlarges, definitely this is something which will enlarge. Adrenal will also enlarge. So all these factors can be there.
Graves' disease occur due to thyroid receptor antibody, which stimulates TSH receptors, resulting in development of goiter, present with eye signs and hard to form swelling, resulting in increased hormones, both high T3 and high T4 levels, resulting in decreased TSH levels. It is severe, persistent with both thyromegaly and eye signs, and we can use anti-thyroid drug as a treatment or surgery can be opted. Multinodular goiter, multiple nodules present in goiter, resulting in increased levels of T4 and a decrease in TSH levels. There is a risk of malignancy and can present like subclinical thyrotoxicosis. Thyroid nodule, coming to thyroid nodule, it could be extrathyroidal, which includes teratoma or cyst. Thyroidal, which can be benign like adenoma, thyroglossal cyst, and ectopic thyroid tissue, or malignant like papillary follicular carcinoma, medullary carcinoma, or lymphoma. Now, coming to assessment.
Thanks, Devisha, for covering this part. So we'll talk about the assessment of thyroid disorders. So thyroid swelling assessment, the key questions that one has to answer is it really a goiter? What is the cause? And what is finally the effect in that perspective? So when we talk about swelling, we need to really classify whether it is a diffuse swelling or a focal swelling. This is extremely important because both have different implications. If it's a diffuse swelling, this is more likely to be a goiter where you are mainly looking into functions of thyroid, and histology will not be extremely important. While if there is a focal part which is involved, that could be a nodule or a hemagenesis, here the chances are that you need to think of malignancy as a significant aspect in that perspective. Now, the next step, of course, is to look at ultrasound. Now, ultrasound clearly in goiter, we are looking at mainly in terms of the size of the goiter, the vascularity of the goiter, and we are also looking at in the perspective of whether there is any particular nodule that we are able to find that in that perspective or not. So there are formulas by which you can use using an ellipsoid formula for thyroid to calculate its volume and take both the lobes in that perspective. Now, very importantly, you have to have criteria which depend upon the age, the iodine status, and the body surface area. So generally, the volume is around 0.9 ml at birth, and then it increases to 3.1 to 6.3 ml. So this is the volume which will tell you how large the thyroid is. And as a rule of thumb, you can say the terminal phalanx of the thumb. This is what the criteria is as far as the thyroid size is concerned. So if you don't have an ultrasound, you can see, okay, your terminal phalanx of the thumb of the child, how big the thyroid is from that perspective. Now, there is, of course, a WHO grading which talks about the staging of thyroid in terms of having no goiter, palpable, but which is not noticeable. Then it is noticeable on extension of neck, that is 1A and 1B. Then we are noticeable on normal position of neck, that is stage 2. And then finally, you have a large goiter which is seen at around 10 meters. So it's mainly a sort of a thing to look at community screening of thyroid. It's not giving you idea about the volume. So better would be from a clinical perspective to actually measure the dimensions of the gland, look at whether there is any irregularity of the surface, whether there is nodularity in the surface. That becomes important. So once you get to know this is thyroid, you start a complete history and examination, go for family history for goiter and hypothyroidism. So usually if there is a strong family history, we have seen many siblings who come to us with delayed onset diagnosis of hypothyroidism, mild developmental delay, extremely soft rubbery goiter, that is dyshomogenesis as a classical case, or iodine deficiency. The other features, of course, for hypo or hyperthyroidism should be considered. If there is deafness in somebody who has hypothyroidism, think of a Pendred syndrome, or iodine deficiency can also cause similar scenario. Some children can have thyroid hormone resistance in which they can have ADHD-like presentation. So thyroid swelling with attention deficit hyperactivity, unusual thyroid functions, T3, T4 is high, TSH is also high. So that is going to be a feature of thyroid hormone resistance. Look for history of exposure to anti-thyroid drugs. Dr. Nimesha talked about lithium, amiodarone. Amiodarone is very, very important, particularly in individuals with younger children where they are using for cardiac arrhythmia. Then that is the most common scenario where amiodarone is commonly used, and you can have a later onset of thyroid dysfunction. Amiodarone can cause hypothyroidism, it can cause thyroiditis and hyperthyroidism, or even a thyrotoxicosis like picture in which the thyroid hormone production is high, and you can also have a thyroid swelling from that regards. Exposure to iodine is something which you want to be clear in that regards. Now, how do you identify goiter in a newborn period? It may be visible, but often it is not very clearly visible, and therein lies a proper examination. So how you should position the child is the child should be in the lap of mother with extended neck. So it should go down from the mother's thigh, you go a bit long, and then you palpate in between the cartilage ring and your fingers. If you feel any resistance, that means that there is a thyroid swelling which is there. If there is no resistance, it is most likely that this is a case of genesis of thyroid, and this we often do in the perspective of hypothyroidism and congenital hypothyroidism. For the older children, you have to look at the normal examination pattern, start off with inspection, whether this is a symmetrical gland or not. Look for whether it's moving with deglutition and protrusion of trunk. If a swelling is moving with deglutition, it means that there is a thyroid swelling. If it's moving with tongue protrusion, it is going to tell you that this is more likely to be a thyroglossal cyst. So these things will give you a clear-cut clue. Do a palpation and always do it from the behind, and be careful that you do not cause carotid sinus hypersensitivity. Some people have that and they may develop syncope in that perspective. So palpate for the margin, the size and other parameters, and also whether its consistency is soft, firm, rubbery or bossulated, which I'll talk a bit later. Very importantly, in children who have got large gland, you can do a percussion to see whether the node there is dull or not, and that will give you a clue that this we are dealing with somebody like a retrosternal extension of the goiter, which may have significant implications. Another sign of retrosternal extension is that you ask them to raise their hand for some time, and then after that, it may cause a superior mediastinal compression like syndrome. What is this sign known as? So Pemberton sign is something we should look at in large goiter, not for everybody. And often something which is missed is auscultation. So you should look for whether there is a bruit which is present or not. That will indicate you increased vascularity, particularly in somebody where you're differentiating Graves versus thyroiditis. This bruit can give you a lot of information from that perspective. So if there is a firm bossulated goiter, think of a lymphocytic thyroiditis. If it's a soft and rubbery goiter, it is most likely dyshomogenesis. If it's a firm but diffuse goiter, especially if there are features of thyrotoxicosis, think of Graves' disease as a possibility. If there is tenderness in the thyroid swelling, that could be subacute or acute thyroiditis, which can be there in that perspective. And of course, if there are multiple nodules, that will be like a multinodular goiter, which is there, which is less common in children. Now, once you know, you need to know what is the effect of the thyroid swelling. So look for all the features of hypothyroidism, short stature, pubertal abnormality, coarse skin, constipation, features of cardiomyopathy that will point towards hypothyroidism, or features of hyperthyroidism like weight loss, tremor, anxiety, periodic paralysis, polyuria. Most children who come to with thyroid swelling may not have an overt symptom. Now, what you need to understand is that children who have thyroid swelling and hypothyroidism generally have milder form of hypothyroidism than somebody who has a completely atrophic form of goiter. If you remember, the most severe cases that come us, they don't come to us with goiter. There, it's a completely damaged gland and you don't find it's an atrophic one. So this is something, so often the clue of hypothyroidism may not be there also in these scenarios. So the most important test, of course, is thyroid function. Then we should do both FT4 and TSH along with TPO antibody, because that's going to tell us the clue as far as diagnosis is concerned. We should consider ultrasound. So everybody who has a thyroid swelling should have an ultrasound. Why are we doing that? Of course, if it's a nodule, then definitely we have to do an ultrasound. But if there is no nodule, in that perspective also, we should look for whether there are nodules present or not in a goiter, because that gives you a clue in terms of diagnosis. And TPO, if it's positive, definitely we should get it done in that perspective. FNAC is done mainly for a multinodular goiter or in the setting of a nodule which is present. Every single individual nodule is considered separately. So when I am talking about malignancy risk for a solitary nodule, the same risk will go for a multinodular goiter. For every nodule, you judge whether this nodule requires the FNA or not. So typically bigger than 1 centimeter, and suspicious features, which I'll talk about for a nodule from that perspective. Nuclear scan is mainly done in the setting of thyrotoxicosis, because that's what you want to differentiate. And urinary iodine, which Dr. Nimesha talked about, is not a good test for an individual. It is a good test for community screening, or it could be a good test for excess of iodine. It's not a good test for iodine deficiency, but if somebody has got iodine exposure, there the urinary iodine can be sky high, and that will give you a good picture. Like if I talk about estrogen in precocious puberty, normally I say estrogen is not a good marker. But if you have a peripheral precocious puberty, ovarian cyst estrogen may be hundreds, that can be easily picked up. Same as here, urinary iodine, if it's very high, it means amiodarone, iodine, betadine, povidone, whatever exposure is there from that regards. So how do we approach a child with goiter? Do the basic thyroid functions. If you have a high FT4 and a low TSH, that's clearly a Graves' disease. Not much of a confusion there. I would not do a scan if there is a classical feature of Graves in that perspective. If, however, your FT4 is high and TSH is detectable, this is rare in children. You can have a thyroid hormone resistance or rarely a TSH producing tumor. If, on the other hand, FT4 is low and TSH is less than 20, this is again a red herring that this could be central. We should evaluate for hypothalamic pituitary function. If it's more than 20, this is clearly a primary hypothyroidism. If FT4 is normal and TSH is less than 6, generally we follow up More than 10, we consider treatment, and 6 to 10, we should get a TPO antibody to get a treatment perspective from that regard. So if you look at FT4, TSH, and TPO, in most cases, you will be able to identify the plan as far as treatment is concerned. Now, what about STN? Now, we should always be more bothered about solitary thyroid nodules. So whenever you're looking at thyroid, look at whether there is actually one region which is bigger or not, because that is the main reason where malignancy risk is there. So this is characterized by not a diffuse, but a focal. One part of the gland is enlarged. I talked about incidentallomas that can be picked up as part of PET scan, carotid Doppler, neck CT. In those scenarios, the main evaluation does not change. The only thing to remember is that if you identify that as part of PET scan, the chances of malignancy are a bit higher as compared to an incidental clinical detection. So it's similar. So PET is associated with a higher malignancy risk. So what is the most important question in a case of nodule? What is the risk of malignancy? So what we need to look at, is there any predisposing factor in the family or the child in the treatment in that regards? Examination, the size, the consistency, the cervical lymph node, they will give you a clue. What's your thyroid function? Hyperthyroidism is good in this perspective. If you have a low TSH, you are more likely to have a benign lesion. Hypothyroidism is bad. If your TSH is high, you are more likely to have a malignant lesion in that perspective. Nuclear scan, typically in the setting of thyrotoxicosis, ultrasound, pretty much everybody will require an ultrasound, and most with a lesion size more than 1 centimeter will require a fine needle aspiration, because 7 to 14% chance of malignancy is quite big from that regards. So on history, ask specifically for radiation. Remember case number 1, your entire picture changes if there is a history of radiation, because then the chances of malignancy become a lot. Ask for family history, and there are often predisposing syndromes also which can cause thyroid cancer. On examination, you have to look for features of malignancy, which is size more than 1 centimeter, rapid enlargement of the gland, fixed gland from that perspective, features of anatomical suppression like vocal cord paralysis, lymph node will suggest an aggressive lesion in that regards. Rarely look for features of MEN2, especially if you're thinking of medullary carcinoma thyroid, like bumpy lips, skin thickening, itchy lesions like amyloidosis, Cowden syndrome in which you can have hematomas, and Carney's complex which is associated with other features like perioral pigmentation, lentigenes, they can be present in that regards. Now, based upon the level of TSH, you can then decide what is the likelihood of malignancy and what workup is required. If your TSH is below 0.1, this is most likely a toxic nodule. You should get a nuclear scan, and that should give you a picture from that regards. FNA is usually not required. The only situation where you do a FNA in somebody who has got a toxic nodule or quote unquote toxic nodule is that if it is a hot nodule, in which the periphery of the thyroid is not completely suppressed. If it's a cold nodule, of course, that's a different ballgame. FNA is absolutely indicated. If the TSH is 0.1 to 1, it may be possible that this could be autonomous lesion. So when I talk about FNA criteria, when you have atypia of unknown significance or a follicular lesion of unknown significance, stage 4, in that scenario, you may save a surgery if you get a scan which shows an increased uptake in that regards. If the TSH is more than 1, you should definitely go for ultrasound and then decide about the FNA. So TSH is the first starting point as far as the management is concerned. So this is what looks like an autonomous nodule. You don't need to do a FNA. This is a cold nodule. What you are seeing, all the other parts of thyroids are looking dark, but the central part, the nodule is not picking up. FNA is absolutely essential. What you need to do also is in the setting of if you have an indeterminate lesion in which the lesion is bright, but the other regions are also picking up. So in that scenario, what you're looking out in that perspective is that this requires definite evaluation. This is what is known as a warm nodule from that perspective. Now, ultrasound, as I said, anybody who has a normal TSH, ultrasound has to be done, and it should be done by experts who are aware about evaluating the pediatric ones quicker. There are Thyroid scoring system, which is a staging system for adults in which they have scores which tell you whether the chance of malignancy is more or less, whether you need a FNA or not. In pediatrics, the Thyroid system has not been fully explored. But yet some of these conventional features may be relevant. So ultrasound is done in all, especially for a cystic nodule, and tells you to decide about FNA and aspiration. It may also be helpful to confirm nodularity in somebody who has got goiter, and sonographic features, you can pick up lymph nodes as well. So these are mainly from the adult guidelines, but many of them typically go for children as well. So if there is a irregular margin taller than wide. Now, this is not very relevant for pediatric. Taller than wide is more for adult, but irregular margin definitely. Microcalcification, if it's present, or the rim calcification is there, 70 to 90% chance of malignancy. So your likelihood of a malignancy goes up by 5 to 7 times, 7 to 14% to 70 to 90%. So very, very high chance of malignancy. If there is a regular margin, then there's a 10 to 20% chance, especially if there is a hypoechoic solid lesion. If, on the other hand, you have a hyperechoic, more bright lesion, or a same echoic or solid cystic area, the chance is less. So depending upon your ultrasound findings, you can then decide about the need for that. In the Mediclasses application, we have got a tool which will help you identify the size and the level of finding on ultrasound to decide whether FNA is required or not. Very clearly, if you have a purely cystic lesion, then FNA is not going to help you a lot because the risk is very, very low in that perspective. So if you have a cystic lesion, FNA is not required. If you have extra thyroidal involvement, or if there is compression, extrusion, you don't need to do anything from that perspective. Otherwise, as the size go up, you need to decide about spongiform nodule. The in FNA should be done after 2 centimeters. If you have these sort of patterns wherein the risk is slightly intermediate, you want 1.5 centimeters. If there are high risk patterns like microcalcification, rim calcification, then at 1 centimeter. Also remember that younger the child, the size criteria may vary. So you may not wait for 1 centimeter for somebody who is very small, but otherwise combining ultrasound and size will give you a picture. So if size is less than 0.5, never. You don't need to do a FNA. 0.5 to 1 if there are features of extra thyroidal involvement. Above 1 centimeter if there is solid lesion, irregular margin, micro or broken calcification. Above 1.5 for solid cystic lesions, and above 2 centimeters for spongiform lesions. So this is how you should decide about FNA. If it's a purely cystic and you are confident, then FNA may be avoided in that perspective. Now, suppose you have got the FNA and you didn't find anything. How do you follow? You are being following if it's suspicious lesion less than 1 centimeter at 6 to 12 months, low or intermediate at 12 to 24 months. If the risk is very low, you can follow up after 2 to 3 years also, because these people, they will ask is, when do you want to come back again? And the size increases, then you do that. Now, FNA in children, again, you have to be very cautious. It should be ultrasound guided. We don't want blind FNAs in children. That is not going to help you out. So there is a chance of false negative because it's a large lesion you have picked up from one site. That may be a sampling issue. So you may have to do multiple sites if the lesion is very big. If there are multiple nodules, as I said, every nodule should be assessed specifically. And if that nodule clearly meets the criteria, maybe you need to do it in 2 nodules, 3 nodules, whatever, but it has to be done because they are not all going to be the same. If there are no feature, then you choose the biggest nodule, of course, because that is the scenario. If it's non-diagnostic, then you should do an ultrasound guided. Ultrasound guided, definitely pediatric. Every case we should do, as I said, this is particularly helpful for a posterior nodule in that regards. Now, once you do FNA, you will get a sort of a scoring system from FNAC, and that is based upon the NIH, the Bethesda classification. And this is very, very important because now, earlier people used to report a lot of confusing scenarios in the cytopathology, but now they have been restricted to give whether there is a category 1, 2, 3, 4 or 5. So category 1 basically means non-diagnostic, which means that still the malignancy risk is there. You have to repeat that, or you do a core biopsy if it is not there. If you are in doubt, go for surgery. Category 2 is purely benign. The chance of malignancy now becomes very less, 0 to 3%. Repeat an ultrasound after 12 months, and if the size is increasing, then only you do a fine needle aspiration again. The problem usually happens in category 3 or 4, which is atypia of unknown significance or follicular lesion of unknown significance. In this, now a good thing which has happened is the availability of molecular studies. So what do these molecular studies do, Nimisha? So which molecules do you assess? So they are basically genetic studies to look at what is the cause of this somatic mutation. So essentially, as I said, there's nothing idiopathic. So these lesions will have somatic mutations. Some of them will have high risk of malignancy. Some of them will have low risk of malignancy. So based upon that, you will get a report. Malignancy risk less than 30%, 30 to 70%, more than 70%. So this is what you will get. So AUS and FLUS, you should get a molecular study, which is now the standard treatment. Or earlier we used to say do a repeat FNA after 6 weeks. If in doubt, go for surgery. 5 is likely malignant or suspicious. Chance of malignancy is pretty high. Go for surgery. You can do a molecular study here to decide whether you want to go for a lumpectomy or a thyroidectomy, a nodule only removal, or a complete removal in that perspective. If you have clear-cut malignancy, of course, that is 97 to 99% malignant, you have to go for a near total thyroidectomy. And we are not going to talk about the types of surgery because that's different. So main message for a pediatric perspective is that if you have a thyroid nodule, there's a high baseline risk of malignancy. Get an TSH, an ultrasound, and if needed, FNA. Do not avoid it, because if you pick the thyroid carcinoma in children in an early time, it has got a very good outcome from that regard. But if there is a metastasis, the outcome becomes very bad. So if category 1, this is non-diagnostic, repeat it. Category 2, benign, follow up. If the size increases by 20%, then you go ahead with repeat FNA. 3 and 4 go for molecular study. 5, clearly you have to go for surgery. 6, clearly you have to go for total thyroidectomy. So that is something which is very, very important from that perspective. So if your TSH is less than 0.1, get a thyroid scan, increase uptake, surgery. Very important recommendation. In adults, toxic nodules are being treated with radioactive iodine, but not in children. The safety is not proven. There could be a chance of malignancy. So definitely surgery is the treatment of toxic nodule. If it's cold or unclear, go for FNA. If TSH is above 1 and size and ultrasound criteria, more than 2 for spongiform, 1.5 to 2 for mild, 1 to 1.5 for suspicious, and 0.5 to 1 for invasive, in all those scenarios, go for FNA. And then based upon FNA, you decide. If it's non-diagnostic, you do a repeat. Benign follow-up. AUS, FLUS, go for molecular study. Suspicious malignant, go for surgery. So if you remember this will pretty much take care of all your issues in terms of solitary thyroid nodule. So 8-year-old boy with thyroid swelling, Dr. Alapan, what do you see?
Midline swelling.
Since birth? It's mobile. So what do you think is goiter?
Doesn't look like a thyroid swelling. Rather than we should like to look to ask for the movement with deglutition as well as protrusion of the tongue.
So there is slight tenderness, and they say it's a off and on swelling. It comes and goes. And when it was moving with tongue movement. So this could be a thyroid. This is typical. It's much more superficial if you look at it compared to actual goiter. It's very superficial. So yes, and surgery is very, very important. And this could be ectopic also. Second differential is ectopic also can present like that. Surgery is important because of the risk of infection and malignancy, which is there. 8-year-old boy with goiter, Nimisha, height is 108, so short stature. FT4 is 6, TSH is 44.
Primary hypothyroidism.
So will you do TPO here?
We will do TPO to see.
So it's not essential, but you can do. But definitely, this is primary hypothyroidism. TPO here is negative. What do you think? 8-year-old child who is short, but developmentally he is fine. What will you look for clinically to make a decision? So what do you think this is? This is unlikely to be dysgenesis. It could be dysharmonogenesis. So you should look for the thyroid uptake, which will give you a clue. You can look for the thyroid swelling. It will be a very soft and rubbery goiter. So this was a dysharmonogenesis. Ashutosh, 15-year-old girl with firm goiter, reasonable height, FT4 is 12 and TSH is 2.2. So both are normal. What will you do? Will you treat? Will you give iodine or thyroxine? Scan. So there's normal thyroid functions. So clearly this is what we call puberty goiter, quote unquote, colloid goiter, whatever term you want to use. I can say physiological goiter, but the trick here is that TPO is positive. So what will you do, Alapan, here now?
This would be a case of early of the starting of autoimmune.
Treat or not to treat?
I would like to not treat in this patient because we will treat on the basis of FT4 and TSH only.
Yes. So this TSH is not causing the thyroid to enlarge. So treatment is not going to help out. If at all, it is infiltration. So which is not going to be helped by treatment at all. So on follow-up, the TSH is going up. Then you can be justified to treat in that regards. Another case, a 15-year-old girl with thyroid swelling. Again, what we are seeing, FT4 is 48, TSH is undetectable.
Level of the FT4 in this girl child, probably it is a case of hyperthyroidism, obviously, and probably a case of Graves' disease.
Yeah.
I would like to know whether eye signs are present or not.
So large goiter and eye signs. This is classically a case of Graves' disease, and we can manage from that perspective. Nimisha, 14-year-old girl with thyroid swelling, 3 into 3 centimeter nodule is there. Now this nodule is mobile. You can see like this. There is also weight loss and tremor. So what will you do further?
We'll do thyroid function test first.
Yes, FT4 is high, TSH is low, but it's not that high as what the last case was.
Nuclear scan.
So nuclear scan shows this.
Hot nodule.
So hot nodule. So you will go for
Surgery or
you have to start treatment. So you have to start treatment with methimazole and go for surgery, because otherwise you will give methimazole for life. So you have to go for definitive treatment. After stabilization, you should definitely go for a surgical intervention. 17-year-old boy with thyroid nodule, Ashutosh, 1.2 into 1.5 centimeter, a firm nodule. Tremor and palpitation are present. FT4 is 28, TSH is undetectable. So you will do a scan. Scan shows increased uptake, but the surrounding tissue is not suppressed. So compared to the Nimisha's case, where it was a hot nodule, this is different. What will you do? So it is cold or unclear. If you look at TSH is low, thyroid scan is cold or unclear, you should definitely go for a FNA, and it may show a malignancy. So what I'm trying to say is that you have to be very cautious in somebody who has got a non-suppressed peripheral thyroid tissue from that regards. Alapan, 16-year-old boy with follow-up case of Hodgkin's. We discussed this in the beginning. And with cervical radiation, normal thyroid, but TSH slightly on the higher side, TPO is negative. Do you agree that no treatment was a good policy?
In setting of cervical radiation, you should always
definitely go for treatment for subclinical. That is one of the absolute indications for treatment if there is a high risk of radiation or malignancy, and this could be a problematic scenario. 14-year-old boy with thyroid nodule, recent onset, rapidly progressive, 1 centimeter, and ultrasound shows a solid cystic area. Will you wait and watch, or you will go ahead with a FNA?
We'll follow up and
solid cystic area, I'm not very happy in that scenario. So this is 1 centimeter, but I'll better be thinking of FNA becomes important. FNA is now non-diagnostic.
Follow up and look if there is increase in size or increase in volume.
And you have to know, if it is non-diagnostic, you should ideally repeat it. Non-diagnostic is category 1, that is category 2. So this case should have been done repeat, but he did not come to follow up. But then it developed into malignancy. So we need to understand that non-diagnostic is not the end of the story. It means your sample, you have not done the test basically, that the sample was inadequate in that perspective. 15-year-old girl with thyroid nodule, there's a mobile nodule, no lymph nodes are there. So no axillary cervical lymph node. TSH is normal. There is no history of radiation or family history. Ultrasound shows 0.8 to 0.7 centimeter. And they have reported no features which are concerning. Will you do FNAC here? So 0.5 to 1 only if there are invasive features. There are no invasive features here. So clearly we do not need to do a FNAC. Follow-up will be important. Now coming on to the treatment, mostly treatment is surgical. If there is dysthyroid, you will give thyroxine or methimazole. Euthyroid cases do not treat unless the TSH is above 5 and TPO is positive. Multinodular goiter, definitely be careful from that perspective. Fetal goiter is something which is being picked up also now. That is mainly because of maternal graves in most cases of maternal antithyroid. Look for size. There is limited role of doing FT4 TSH, and some people have treated for maternal for Graves' disease and increased dose, which will help out. Some people have used amniotic LT4 for severe respiratory difficulty. So a couple of reports are there in which the goiter was so big that the fetus was having a problem. There they give the amniotic LT4. Surgery clearly for compressive symptoms or mediastinal extension, and thyroidectomy is the procedure of choice. So we'll now hand over to Dr. Alappan for the Q&A session, and we will ask people to give the answers on that. इसको क्या minimize करना पड़ेगा?
Please आप देख लीजिए.
So Dr. Alappan, yeah.
Thank you, sir. Good afternoon, everyone. So I'll start with some questions. Coming to the first question, this is a USG of a primary gravida mother, 20 weeks gestation, and we found that there is a swelling in the fetus around the neck. The mother is euthyroid. There was no presence of any autoantibodies, and chondrosynthesis was done, showing a TSH level of more than 90. So in this case, initially it was managed with oral thyroxine to the mother. On subsequent follow-up, the child has developed hydroamnios. If the mother has developed hydroamnios, and the size of the goiter increases, as you can see from this graph. So can anybody tell what is the cause of this hydroamnios in this mother?
What is the cause of polyamnios in this scenario? Anybody is giving an answer? And what
the second question is, what is that if the mother is developing polyhydroamnios, what is the treatment? And the treatment is given already. You can see the marks, the arrow pointing in the graph. After giving that, the thyroid volume decreases as well as the amniotic fluid.
So I think there's an issue of the chat. We'll just check it once whether it's working or not. So what do you think, Alappan, should be done in this scenario?
So probably, sir, developing a hydroamnios, the child is either passing urine more or not engulfing enough urine. So probably it is case of a compression to the esophagus that causes the deglutition maternal amniotic fluid. So polyhydramnios is a sign of probably a compression in this case, and we can go for amniotic LT4 treatment in this case.
So amniotic treatment can be considered. So this is coming in Q&A, I think. Yeah. So Dr. Aisha is talking about intraamniotic LT4 and poor swallowing of baby.
Yes,
You agree with that?
Yes, sir. Right.
Yeah. So I think that's a very, very important presentation. And we discussed this about also like that this could be an issue which is there from that perspective. Yeah.
Yes, sir, I can do that. So this is something published on 2014, the ISPE guidelines for congenital hypothyroidism. They had mentioned about this progressive hydroamnios and premature labor or any compressive symptoms which we can treat with intraamniotic LT4 treatment. So moving on to the Moving on to the next case of 4-day-old neonate with presented with goiter. The mother is having Graves' disease and on treatment. So can anybody tell about the causes of goiter in this? What could be the causes of a mother having on antithyroid treatment with Graves' disease and baby having goiter?
So I think that's something which we discussed. There are two possibilities which we're thinking of.
One is
Anybody you can put up on the Q&A. We've got from Dr. Aisha, TRAB antibodies.
yes.
And Dr. Arushi is saying maternal antibodies, maternal antithyroid drugs. So that's the perfect answer.
Yes. So both of them can cause this kind of goiter in the newborn, and the investigation now after delivery, it is showing a high TSH level. So probably this is one that maternal drugs crosses the placenta and goes to the baby and causes this hypothyroid-like picture. But 2 weeks later, the child developed hyperthyroidism. So this is what Sir has already explained about it. Ki sometimes the maternal drugs crosses the placenta, goes to the baby and causes hypothyroid-like picture. But at the same time, the trap antibodies also passes to the baby, and that can cause, as if it is a stimulating one, it can cause a hyperthyroid-like picture. So his alternative picture can be seen.
And that is because the half-life of the TRAB is 3-4 times more as
Than the
compared to that for the drug.
Trap.
The drug is like 2 days. This is more like 2 weeks. So that's why
Yes.
you will have hypothyroidism followed by hyperthyroidism.
Hyperthyroidism.
Carry on.
Moving on to the next case, a 8-year-old girl child presented with goiter. On examinations, there are eye signs were positive. It is a quite large goiter. FT4 level was high with a low TSH level. Anybody with diagnosis? Would you like to do a TRAB antibody here?
So we are looking for the answer. So this child clearly has clinical features. Dr. Aisha is talking about Graves' disease. Yes. Do we do a TRAB? That is a bigger question here. Or do we do a scan? So this child has got everything. He has got large goiter, eye signs, very high FT4 levels. This is very, very clearly a case of Graves. So unless you've got a lot of money to waste, you don't need to do the test
Yes, sir.
in that regards.
So the next
So
question.
Dr. Arushi has mentioned not routinely required. Prashant has mentioned scan. Yeah, carry on.
What is the best test to differentiate between Graves' disease and thyroiditis?
So when you mean best, what do you mean by best?
Sir, the gold
High
standard.
sensitivity, specificity.
Yes, sir. That's matlab, clinically, I'm sitting in OPD. What will be my best test? Matlab, I just want to know the opinion from everybody.
Okay. So whether you want, so basically Dr. Alapan is asking whether you want to do a TRAB or a scan.
Scan, yes.
So scan is clearly the gold standard, but then when you say best, you have to also look at the cost, the
Financial
radiation exposure, and a lot of other factors.
Easy to
Availability, all those things are also
important. So the treatment also options, I'm not going into details. You all know that methimazole can be given. P2 is not given in case of children, and other therapy like radioactive iodine and surgery can also be considered. Moving on to the next case, 8 years old boy presented with short stature and constipation. Examination showing a diffuse enlargement of thyroid gland. And this case has been already discussed. The TSH is normal, FT4 is normal, but there is a TPO positivity. So anybody with the diagnosis?
And you have to be more precise about the type of thyroid swelling in terms of texture.
This is a kind of a palm swelling. Margin is not that smooth, rather bosselated like swelling.
So you have given the diagnosis. I think most people will be able
Yes.
to answer.
It's probably early cases of autoimmune thyroiditis, and the question was whether it has to be treated or not. And
so when I had started the practice, a lot of people used to give iodine. A lot of people used to give thyroxine routinely for goiter for suppressive therapy. Even experts also were using that. So clearly, it's very clear to understand that there's no role in that perspective. Now here, when will thyroid help? This is what I alluded to also, is that if your TSH is high, then bringing it down may help you. But if the TSH is normal, this is infiltrative swelling, then thyroid treatment is not going to change. So I would not be thinking of treatment, but following up will be important.
Moving on to the next case, a 14-year-old girl presented with a swelling of in the neck, probably in the thyroid region on the right side, And there are mild features of thyrotoxicosis like tremor, anxiety, palpitation. You can show the see the thyroid function in this case. FT4 is high and TSH is low. So how would you like to proceed? Would you like to go for a USG or FNSC? You can see the answer is given already there.
What's on the scan?
So this is a thyroid scan that has been done. So technetium part technet scan was done in this case, and so there is no role of USG. We can see the TSH level, and we can go for a. This is a hot nodule. You can see, and the scan is showing the hot nodule here.
So for a hot nodule, you don't need to do anything. What will you do in terms of treatment?
So initially, we can go for methimase therapy to decrease the thyroid level, and then we can proceed for the surgery in terms of. So 12-year-old girl child presented with neck swelling and difficulty in deglutition. The thyroid profile is normal. You can see the USG, which is showing a colloid cystic swelling. So do you think there is requirement of FNAC in this case?
So it's considered mentioned as a colloid nodule.
Yes.
But colloid nodule generally they will write in the FNAC, not an ultrasound.
Yes, sir. Actually, I've written colloid nodule, but the structure is completely cystic. Actually,
So completely
cystic nodule.
lesion. So as Dr. Aisha is saying, that there is no need of any FNA from that regard.
So when you like to repeat the test, whether you would like to do FNAC in cases of benign lesion, in a benign nodule, when you would like to repeat the test.
So generally we will be doing it after. So how much time people have mentioned? Generally after a year.
Yes.
If there is no indication of FNAC, we should do not routinely also. If there are some other feature, then you will do it after a year.
Moving on to the next. Okay. So this is something that Sarah has already described when to do FNAC in cases of according to the size and also the lesions that has been present, the USG characteristics of the lesion and based on the ADA guidelines. Moving on to the next case, a 15-year-old girl child presented with diffuse neck swelling with a palpable nodule. The thyroid profile was normal. What could be the next best step in this case?
What do you mean by next place?
Because USG has been already done, I just want to know whether you are going for the
Whether FNAC is
FNAC is
required or not in this scenario.
So FNAC is definitely required in this case because the question was whether the USG alone, the USG characteristics alone is sufficient to diagnose a carcinoma like thyroid. And they had already published guidelines in 2022. They had shown that not only the USG criteria, but we have to always adjunct with FNAC to prove that this is a case of a malignant lesion. Moving on to the, and this is the Bethesda classification that Sarah has already mentioned, 2022, there is a new Bethesda system classification.
This is important in terms of what is the risk of malignancy.
Malignancies.
So if you're looking at malignant, it's like 97 to 99% typically.
Yes.
But if you talk about AULS and FULS, then the risk of malignancy is around much different. So what is this NIFTP? Okay. So these are different scoring systems in terms of that.
Moving on to some fact checks, like thyroid, I'll give you some questions and you have to tell me whether it is a true or false. So first one is the thyroid scan is a diagnostic of ectopic lingual thyroid.
You can just put in yes or no. We will announce the name of the fastest finger first.
Dr. Arusi Rai said it is true.
True. So it's correct.
Yes, it is correct. Moving on to the next one, the absence of goiter excludes dishormonogenesis. Prasant
says no.
Says no.
Aisha says no. So absence of goiter, will it exclude dyshomogenesis? Yes or no?
No, sir. Obviously, there could be situations where it can be present without this.
Generally, these questions are always false when you have double negative.
Yes, sir.
So we should not make double negative questions. It's a bit convoluted question. We carry on.
Moving on to the next one, stage 1B goiter is noticeable on extension of neck. Stage 1B is according to WHO grading.
Yeah, so this we discussed.
So this is
True or false?
anybody with answer? Prashant, this is true.
So it's true.
I've done the mistake, sir. It is true.
It is true. Yet carry on.
Moving on to the next, Tempatance and positivity explains retrosternal extension of goiter.
So this is what we discussed also. So
Yes.
it's
this-
definitely on
this
the
is
yes
true.
side.
So the next one, malignancy risk of thyroid nodule by FNAC grade 5, 2023 Bethesda classification is 97 to 99%.
So I think this also we have discussed. So what is the risk there?
So around 50 to 75% risk is there actually.
Yeah. Because that's for category 6.
6 is for
5 is suspicious,
suspicious.
or likely malignant.
Yes. Next question is, Hashimoto thyroiditis is always associated with a form of oscillated goiter. That is already mentioned about, yes.
So, but when you say always, that's never going to be true in medicine.
It is always some,
So most likely
Most likely.
associated with that.
so it's no, there are atrophic variants where
Yes.
goiter may not be present.
Mm.
Next question, the Mercibac triad consists of exophthalmos, goiter and palpitation. Sanji says yes.
So do you agree?
Yes, sir. This is
Yeah.
correct. Moving on to the next one, the pediatric thyroid nodule has a higher risk of malignancy than the adults.
Dr. Arushi is saying true.
Yes.
Yeah, so there is marginally more,
Marginally.
but not that much high that you are earlier considering.
And TSH level should be less than 0.05 in the post-op cases of medullary carcinoma of thyroid.
So this is out of syllabus, but yes, important question. What are the target TSH on follow-up in medullary carcinoma thyroid? No, we are not bothered about TSH at all in
yes.
NCT because that's basically a non-follicular lesion. It's a medullary lesion.
Yes. The last question, who is this person?
That's your photograph in earlier times. Hashimoto.
Hashimoto, yes, sir. Haruko Hashimoto. Thank you.
Thanks a lot, Arapan, for the wonderful questions that you have compiled. We will be closing the session. You can all go and have a look at our website with all the courses, the books, the application, and we'll see if there are any particular questions besides which are available in that perspective. So there are a lot of questions. Earlier also, there were a couple of questions. Dr. Randa is asking, I have an 8-year-old female patient with nodule that was grade 2 on FNA. It is recurrent, has symptom hypothyroidism for TSH in lowish side, T4 on higher side. And she has severe constipation, sleepiness, but palpitation, but no anemia, other cause of anemia. No, because TSH is normal also and FT4 is also normal. There are some other reasons of that. I would not say that we should treat it on that. I think others were related to the answer from that. So thanks a lot for all of you for joining us and having a wonderful discussion. Apologies again for the delayed start due to technical glitches. I'd like to thank Dr.